currently the board president for the consortium, and welcome to our annual meeting. We have a bunch of people still trickling in, so welcome. It's hard to believe, but this is our 10th year now as a merged consortium, and it's the last 18 months have been probably one of the more interesting times for that consortium. So it seems like we've been merged forever, and I have really very little recollection of us not being together. So I think that's a good thing. We have worked very, very well together and come together as one in ways that I had dreamed of when we first did this. So congratulations to all on that accomplishment, which we have done very, very successfully. As Robin will detail, it's been quite a challenge keeping all of our programs up and running during these challenging times of COVID with isolation and masking and vaccinations, et cetera. But I think her and her staff have done a remarkable job in keeping all of our programs up and running and successful during these trying times. And I want to thank her and the staff specifically for that. I really don't have a lot of other comments other than to say it's been a very successful year, financially and program-wise. So with that, some housekeeping. If you would please, during the meeting, please keep your meeting settings on mute. If you have questions, in the bottom right of your toolbar at the bottom of the Zoom meeting is a Q&A button. If you click on that, I will be monitoring that for questions as we go forward with the various speakers. And you should have received an agenda for today's meeting as well. Now I'm going to give it a few more minutes to let some people trickle in. We're up to 121, so. Okay, so our first speaker this morning is Judith Persicelli, who, as you may be aware, is the commissioner for the New Jersey Department of Health. This is a recorded message from her as there were conflicts in timing. And with that, I will let Robin start that presentation.
I want to thank all of you for being such strong allies in our work to improve the health of women and their children in our state. At no time was that more important than during this once-in-a-lifetime pandemic, when pregnant women faced unique challenges because of their heightened risk for COVID-19. This past year of the pandemic has been very challenging for all of us, but especially for our most vulnerable residents. This pandemic shined a light on long-standing health disparities, making your work more vital than ever. The work you do every day ensures more equitable maternal and infant care and outcomes through connecting women to community health workers, services, prenatal education. As part of the effort to help keep our state strong, we are counting on all of you as health leaders to encourage those you serve to get vaccinated against COVID-19. All of you are powerful voices and resources to listen to the concerns of those who are hesitant to be vaccinated. Answer their questions and help us curb this pandemic. Women in particular, as the healthcare decision makers in their families and for their loved ones, can help encourage vaccination, particularly for the men in their lives and those aged 12 to 17, to help protect them and their families and their communities. COVID-19 vaccination is recommended for all people aged 12 years and older, including individuals who are pregnant, breastfeeding, trying to get pregnant now, or might become pregnant in the future. Vaccination is particularly important for pregnant and new moms because we are finding that they're more likely to get severely ill from COVID-19. Also, remind your clients to get their second dose of Moderna or Pfizer vaccine to ensure they have the fullest protection against the virus. And for those who are immune compromised, they are eligible for a third dose of vaccine to protect their health. So please encourage those who would benefit to get that third shot. At a time when Delta variant is surging nationally, vaccination is the best tool we have to fight this pandemic. Please join us in sharing the facts about COVID-19 vaccination so that together we can protect our state. And thank you for all you do every single day to build a healthier New Jersey. I want to thank all of you for being such strong.
So I'd like to thank you for all being here today, and a huge thank you to the Commissioner for taking the time to record that message for us. I think it is a good reminder. It's something we've been living for the past 19 months. I think many of you would agree that the last year and a half and a little bit more should be a distant memory, and we want to wash it away. However, we have to acknowledge that during this time we've seen great heartache, but also great resilience amongst our community. Our hospital partners and healthcare providers have been stretched to a point where they never thought they would have to go. And our community has been equally challenged in so many ways, whether it's been the pandemic or extreme weather conditions. We in Central New Jersey know that we've had the unfortunate opportunity where these conditions have threatened life, homes, businesses, and through it all, we've remained connected to one another, and for that I'm grateful. I'm grateful for your support that you've provided for all of those in need, particularly to our most vulnerable, and to the collaborations that we've been able to develop, some new, others old, but our collaborations have actually strengthened. So to our staff, our partners, a huge thank you, and I look forward to our continued work together to keep our community healthy and safe. So this particular slide really I wanted to share with you that throughout this time, Central Jersey Family Health Consortium has really been able to fortunately increase our capacity and our ability to serve the community. And in doing so, we've been able to live our mission, which you see here on the slide in green. We've developed new and innovative ways to partner. We're doing things now in a way that we never thought we would do ever, whether it was virtual learning, virtual contact with clients, but it's through that dedication that we've been able to serve all and expand our services. This is just a quick glance at the programs and services that we have here at Central Jersey Family Health Consortium. During the past year, many of the programs you see have actually increased in size, or they've been added to this portfolio to really broaden the breadth of which we have the ability to address our families, their needs, and to keep them in a healthy environment. I wish I had time to share with you the successes we've seen in each one of these programs, but I want to highlight just two this morning. One of the newer additions to our portfolio of programs is the Family Connects home visiting program. This program is starting in Trenton, New Jersey later this year. It's a jointly funded program through the Burke Foundation and the Division of Children and Families. And in this program, every family who delivers at Capitol Health that lives in Mercer County will be entitled to a home visit through the Family Connects program. This home visit will be done by a registered nurse. A complete assessment of both mom and baby will occur. There are additional staff through our partner Trenton Health Team that will also assist in arranging these visits, but also connecting the family to resources that they may need as they become a new or an enlarged family. This program itself will actually serve as a model, and I'm sure many of you are aware of the recent legislation that will now afford every family in New Jersey who gives birth to have a home visited by a nurse after their delivery. We're incredibly excited to be part of this program and to really help work out the logistics of how this program will be rolled out statewide in the near future. We look forward to sharing more about this at our next annual meeting. In the meantime, I'm sure that you will see through our various newsletters and other social media posts our progress as we move forward. The second program I want to talk about is a program that we're doing through our Healthy Women, Healthy Families grant, which is funded through the Department of Health. And within that program, we will be starting a breastfeeding peer counselor program. For many families, breastfeeding peer counselors fill a role by offering compassionate support, encouragement, active listening, and validation of the shared breastfeeding experience. We know that breastfeeding is really critical in helping to ensure a great start in life for many of our families, for those families that choose breastfeeding for their babies. Numerous studies have shown the importance of breastfeeding peer counselors and the effectiveness of increasing breastfeeding initiation and duration to targeted communities. Peer counselors provide a culturally competent support that addresses the special needs of parents of color in order to achieve equity in breastfeeding and decrease racial disparities. And because of this, we're actually going to be implementing a program called Reaching Our Sisters Everywhere Community Transformer Model, or the ROSE program. This particular model is an ideal model for the provision of breastfeeding support in diverse communities and will provide CJFHC with an opportunity to enhance and grow the breastfeeding workforce within our service region. This model will prepare peer counselors, who are called community transformers, and help peers gain confidence in their parenting and their breastfeeding experience by modeling and normalizing breastfeeding. We currently have dollars through our Healthy Women Healthy grant to implement this in Trenton, and our hope is to get additional funding so that we can spread this particular model throughout the 6 counties in our region and beyond the Trenton city limits. Again, these are just 2 examples of programs that are either growing or are new to us, but I can give you examples in each one of these areas of the wonderful and phenomenal work that has been happening by the staff of CJFHC. These are just some quotes from families. We all know, everybody on this webinar recognizes the challenges that we've faced, both in reaching families as well as providing the needed care that we've done in the past. And you can see here that despite changing different practices, going to a virtual environment, not being able to visit, has really not made as much of a difference as we would have thought. We see that we've been able to reach people where they are, to continue to support them through this very challenging time. And these are just examples of different programs. These are quotes from people that have received services from CJFHC. And despite this major disruption and abrupt change in how we've been able to deliver care, it's been done successfully through the support of our staff, our funders, our program managers, and we are eternally grateful to every one of them in making this a possibility. This is one more. We've even had educational programs besides one-on-one type of approach. This particular quote is just a word cloud that was formed after a group that was facilitated by one of our staff. And you can see just by looking at all these different words, this is really what we're all about. And I'm very happy to be able to share it with you. And I would say probably the most proud we are is to be able to start a brand new program here at Central Jersey Family Health Consortium through the generous funding of the New Jersey Pandemic Relief Fund. And that is a program called Pete's Place. Pete's Place is named in honor of a former staff member who passed away over the past year, Pete Baylog, who was an integral part of Central Jersey Family Health Consortium and one of its biggest supporters, both internally as well as externally. And in his honor, we have started Pete's Place, which started out to be something of a food drive that has just morphed into something much more. This particular program will provide essentials for families in need within our region. For families in Hunterdon, Somerset, Middlesex, and Mercer counties, families can reach out through our central intake hub and can request different services, different items such as diapers, car seats, things that one needs when starting a family. We have been able to offer services over the phone, and both in Ocean and Monmouth counties, we've set up with our collaborators through different agencies such as the VNA, Children's Home Society, the Family Success Centers, the FQHCs, all can serve as a referral source and to assist families to reach out to us. We launched a pilot of this program in July with Hunterdon YMCA and United Way to work out the logistics. And since then, well, within the first week, there were 18 families that we were able to assist. We expanded to our Hunterdon and Somerset partners in late July, and then to Mercer and Middlesex just in mid-August. Through just these few months, we've distributed over $16,000 worth of goods, including safe sleep packages, which include pack and plays, safety gates, car seats, over 100 cases of diapers, as well as over 100 cases of diaper wipes, strollers, a variety of gift cards, Lyft gift cards, etc. Items have been ordered through Cribs for Kids, Walmart, Target, Amazon, and these packages have been delivered directly to families to ensure, for COVID reasons, that we limit contact for both our staff and for the protection of families. I can't tell you, this has been years in the making, and to have it finally come to fruition, it makes me, makes our staff, we are so incredibly fortunate. We will be eternally grateful, and we will continue Pete's Place for as long as we can. And there are just some examples of thank yous from families who have received goods through Pete's Place. So if you need to access Pete's Place for the communities that you serve, please do not hesitate to reach out to CJFHC. And just in closing, I'd like to just go through, as we usually do, a summary of what's happened, what Central Jersey looks like right now in 2021. So over the past year, we've served over 16,000 clients, and you can see a variety of people that includes. In addition to that, we've served nearly 40,000 healthcare providers, professionals, and community members through different and various educational programs. Over 400 partners have participated in programs and services that we provide. Safety items that have been distributed not only through Pete's Place, but through our various programs, near 8,000. We've had nearly 4,000 requests for information, whether that came through individually, on the phone, through email, website. Over 190,000 materials, just resource specific, have been delivered. And our current revenue is at about $10.5 million per year. The majority of that revenue comes through grants. Most come through the state of New Jersey through a variety of different departments. We have some private foundation funding as well as donations. When we look at deliveries, Central Jersey, this has been pretty much the same for over a decade. We deliver about a third of the infants in the state at 29,992. Excuse me. Of those, over 29,000 were live births, with just 172 fetal deaths and 58 neonatal deaths. Again, these numbers are about the same that we've seen. Birth demographics, they speak for themselves. You can see the breakdown by race and ethnicity, as well as by maternal age. The majority of births are in that 30 to 34 range, but we do have some teen births and some older moms delivering within our region. When we look at social determinants of health, approximately 26% of the births were to women who were unmarried. About 36% of births are Medicaid covered, and about a fifth of the mothers did have WIC services provided during their pregnancy. Breastfeeding, you can see our breastfeeding numbers across the board. About 74% were breastfed at hospital discharge. Less than that were exclusively breastfed during labor and delivery hospitalization, but that number of those going home have continued to creep up. The majority, the larger percentage are white women who breastfeed, and followed by Hispanic, and then a combination of other, followed by Asian, and then Black women. And you can see the exclusive numbers there as well. When we look at racial disparities and adverse outcomes, we do know that low birth weight and preterm birth are risk factors for infant mortality, and we still do see that in our region. Unfortunately, you can see the difference, though, and how non-Hispanic Black women, or Black babies rather, are disproportionately impacted. And the graph here really does display that, where non-Hispanic Black women are 1.5 times more likely to experience preterm delivery, and non-Hispanic Black women are 3.3 times more likely to deliver a very low birth weight infant, both putting one at risk for infant morbidity or mortality. So we have seen our successes. We still continue to have challenges in our region. Nearly all of our mothers are screened for postpartum depression, and that speaks incredibly highly of the hospitals, the 14 birthing hospitals that we work with within central New Jersey. There is an increasing rate for both a consult and referral for women who have postpartum depressive symptoms, and we've seen that in a virtual world. The need to increase our support groups has borne this out, so we definitely have seen this. And I think this is something our hospitals really need to be excited about, is the decreasing rates of C-sections for women who are low risk. And you can see that curve. This happens to be one of the challenges and that has been picked up by the Nurture New Jersey plan and the First Lady, as well as a lot of the work that's being done in the state, whether it be through the Maternal Care Quality Collaborative or the New Jersey Perinatal Quality Collaborative. And you can see that the work the hospitals have done to decrease this rate has borne fruit and has come to fruition. And at this point, we are lower than the national average. We do still continue to have challenges, and definitely Black infant mortality is one of them. There still is a significant gap in adverse outcomes based on race, and we're not really seeing a change in preterm birth rates over time. So we know there's still work to do in this area. And finally, this last slide is based on some New Jersey Department of Health recently released data, and I would expect we'll be seeing more of this, and we'll have more information to share with you on this, but it ties very closely to the commissioner's remarks, and that is we need to continue to encourage and educate our families about the need for vaccination. Central New Jersey accounts for about 1/3 of COVID cases in the state, and over 9,000 women in our region were identified as COVID positive. Ocean County, one of the largest counties in the state, and also for birthing purposes, numbers of infants, it had the second highest incident rate in the state. You can see the breakdown by race and ethnicity, and when you see versus the percentage of births that we spoke of earlier today. So 41% of the COVID positive patients were Hispanic, whereas they represent only 28% of the births. So again, by looking at these, you can definitely see where we need to target our work. Our mothers do get sick. They're at risk for getting sicker than the general population. And over 2%, we're seeing maternal ICU admissions, and some of the women are dying of COVID. Infant outcomes, we do have some babies testing positive. So this hopefully will give you a sense of where we are in this past year, where we still need to continue to work. And it's a privilege to be able to work with all of you who are on this call today, both staff as well as our community partners. The information I just shared with you is available in our recently released Status of Maternal and Child Health in Central Jersey report. This report will be available on the website. Please download it. Feel free to share. There is much more in this report than you saw here. And I highly encourage you to use this for your own program planning, as well as general information. And now it is my privilege.
Robin, if I,
Yes.
there was just one question for you, and I don't know the answer to this, but I'm sure you do. There was a question about workshops or virtual classes for Spanish-speaking moms focusing on childbirth or breastfeeding.
I am going, now off the top of my head, I can't tell you, but if this person at Genesis, if you could give us your email address, that would be fabulous, and we will follow up with you, because what will be important is to know exactly where you are, whether they're virtual or in person, because there are some places that are starting in-person classes up again. So if you could just, through the chat, and your email will only go to us, we'll get back to you on that. But thank you, that's a great question. All right. So our first speaker today is Dr. Meg Fisher. Dr. Fisher is a world-renowned pediatric infectious disease consultant. She has been in New Jersey for a while, and I know many of you have seen her. We've seen her on the TV recently. We've seen her or heard her on radio ads, but she is, in fact, a wealth of knowledge and, frankly, is highly regarded. She finished her residency and fellowship at St. Christopher's Hospital in Philadelphia and is a professor of pediatrics at Drexel University College of Medicine. She's written chapters in Nelson's textbook of pediatrics, as well has served as editor-in-chief for immunizations and infectious disease, an informed parent's guide for the American Academy of Pediatrics. She's also served on the Committee on Infectious Disease and wrote a chapter in the Infectious Control and Prophylaxis in the Red Book, which is pretty much the Bible for those who are in pediatrics. Since the COVID-19 pandemic, Dr. Fisher has served as a special advisor to the New Jersey Department of Health and to the Commissioner, Judith Persicelli. Again, it is my honor to introduce Dr. Fisher.
Oh, Robin, thank you so much for that. I appreciate it. And it also gave me a chance to go down and let the painter in. So I'm really delighted to be here and to be able to talk to you today. And I'm going to go ahead and get started and go right to this COVID update. Because right now, I think for many of us, COVID is kind of still with us and still impacting our lives, certainly every single day. So whenever I talk about COVID-19 and SARS-CoV-2, the virus that causes it, I have to start with this disclaimer. We get new information about the disease and the virus almost daily. Recommendations change frequently. Last week, we got the recommendation for boosters. The week before that, we heard different things about boosters. So information changes, recommendations change. What you hear that I'm going to tell you today may be out of date by the time I get through saying it, by the end of the week, or certainly by the end of the month. So I encourage you all, use trusted sources to get up-to-date information. And those trusted sources are the New Jersey Department of Health website, the Centers for Disease Control and Prevention website, and the American Academy of Pediatrics. They have a regular website, and then they have a website, healthychildren.org, which is for the lay public and specifically for parents. It's really a guide to help parents make decisions about their children, and I would really highly recommend it to you. It's in English, and there's also a Spanish version. Those are the only two languages we have at the moment, but again, there's just a wealth of information there. So let's talk about COVID-19. So this is the name of the disease that is caused by SARS-CoV-2. COVID-19 stands for coronavirus disease, and the 19 because it started in 2019. SARS-CoV-2, the SARS is severe adult respiratory syndrome. CoV is coronavirus, and the 2 is because this is the second coronavirus that's caused a severe acute respiratory syndrome. Now we know that this disease is primarily spread by droplets. And those droplets are these little spit particles that people form when they're talking, when they're laughing, when they're singing, etc. They go out into the air, and if you have a viral infection, like this coronavirus, then the virus goes out with your droplets. And it's in the air that a person close to you can then breathe in, or it can fall onto their eyes or onto their hands, but primarily it's this droplet spread that causes the disease. We do know that occasionally the virus becomes airborne and can go further than the usual 3 to 6 feet where the droplets generally fall, but that is the less common way that it's spread. The most common way is by those droplets, which will fall to the ground within 3 to 6 feet. Now, I like this next slide because I think it just gives you a great visual. This is a person sneezing. So imagine that there's coronavirus in that sneeze. So that virus is going out into the air, but you'll see most of these droplets, even after a forceful sneeze, are falling to the ground within 6 feet. If occasionally a few of them stay airborne, that's when you're going to get a super spreader event, and you'll have transmission that goes further than that 6 feet. And you may have heard of those events. There was a choir in Portland, Oregon, where everyone in the choir was infected, despite the fact that they were all standing 6 feet away. There was the famous Rose Garden outbreak, which is one of the few, actually the only one I'm aware of, outdoor outbreaks that's reported. So generally, droplet spread, occasionally aerosol spread. Now, if that's the way the virus is spread, here are the things we can do to prevent the spread. We need to wear a mask that's going to cover your nose and your mouth. That does 2 things. First of all, if you sneeze or if you're talking or whatever, all those droplets you're making are caught on the inside of the mask. The other thing it does is when you're breathing in, it filters the air that you're breathing in. So it's a way to control a source, a person who's infected and doesn't know it. And it's a way to protect yourself as you're breathing in the air. Staying 6 feet away is a way to keep away from those droplets. Now, for children in school, we say 3 feet, and that's because for children in school, 3-foot distance has been shown to protect them from the spread. And if they're wearing masks, that is an even another layer of protection. Avoiding crowds and sick people makes sense. When you're in a crowd, you can't stay that 6 feet away, and you don't know who you're standing next to or who might be coughing right on top of you. Washing your hands often is something we tell everyone to do always. It turns out that SARS-CoV-2 is not particularly spread on surfaces, so the hand washing may not be all that important for SARS-CoV-2, but we know it's very important for other viruses like influenza, herpes, and for bacteria like strep and staph. So we also know when you get SARS-CoV-2, you can get another illness. So wash your hands. It's just the smart thing to do. And then as soon as you can, as soon as you're eligible, get vaccinated. When you're eligible for boosters, get your booster. Make sure that if you've gotten the messenger RNA vaccine, if you've gotten one, that you get the second dose. So all of these are important in really bringing this pandemic to an end. Now, this is actually one of the more hopeful graphs, and these show you the daily case counts in the United States on the top and in New Jersey on the bottom. And I've given you the places where you can go to get these. They're updated literally every day. So if we look at the country, you can see that not much disease until April. And if we look at New Jersey, that's when we had our first big peak. Then things quieted down. The country had another peak over the summer of 2020. We did not. Then we had these huge peaks that started in October, increased particularly after Thanksgiving, after the Jewish holidays, and then after Christmas and after New Year's. We then saw a drop. Things became quiet. Same thing in New Jersey. Then we had another little peak here in April of 2021. And then things went down. And honestly, here at the end of June, I think we all thought, oh my goodness, we're finally done with this. And then boom, we got the Delta variant and this other big spike. In most countries where Delta variant has come in, these spikes have lasted for about 10 weeks. We're waiting to see what's going to happen. We think our spike was blunted by our vaccination rate, and our projections are that we will stay at this kind of a rate through the fall. And unfortunately, we are anticipating another peak after Thanksgiving and Hanukkah and Christmas and Kwanzaa. Now, what about the disease? Well, one thing to remember about COVID-19 is you can be infected with the virus, but have no symptoms at all. You could have just a mild cold-like illness. You might think it's just allergies, and that could be COVID-19. It can then progress, and in some people, it will cause pneumonia, multi-organ system involvement, and death. We know that older people and people with underlying medical conditions are more at risk for hospitalization and death. We know that immunization dramatically decreases your chances of hospitalization and death. To date, in the United States, 689,534 deaths. In New Jersey, almost 25,000 deaths. Now, children do have less illness, but they are not immune, and they are not naturally immune. Rather, they are getting infected. We know that about a quarter of the current cases are in children, even though they're relatively mild cases. We also know that there have been 460 or more deaths in the United States in children, and in New Jersey, we've had 8 deaths. We also have this very bizarre multi-system inflammatory syndrome that occurs mainly in children about a month after the infection, so it's called a post-infectious complication. And in this condition, the immune system just goes berserk. And instead of fighting off the virus, it fights off the child. It causes things like shock, the heart problems, lung failure, and just multi-system inflammation. Fortunately, it is treatable, but most of those children require intensive care treatment. And in New Jersey, we have had no deaths. All 133 cases have recovered. However, across the United States, there have been 4,661 cases and 41 deaths reported to date. We also know now that we're seeing more and more of these post-COVID conditions. So these are things that linger after a person recovers from the infection. And this post-COVID syndrome occurs in people who had mild disease, as well as people who had severe disease. And that multi-system inflammatory disease occurred in children who had no symptoms at all when they were first infected, and then presented with multi-system organ disease, high fever, shock, etc. What are the symptoms of this long COVID? Well, there are a whole variety of things: trouble breathing, cough, chest pain, stomach pain, headache, palpitations, joint and muscle pain. And all of these seem to get worse after even minimal activity. Patients are tired, they're fatigued, they have a pins and needle feeling in their extremities. They may have diarrhea, sleep problems, palpitations. They're dizzy when they get up. They have a variety of rashes, some menstrual changes in women. They have mood changes, fever. And then, as you know, you can lose smell and taste during acute COVID, and this can persist during that post-COVID. And most distressing is this brain fog. So people are not able to concentrate. They can't remember things very well. They can't learn new things. They have difficulty for children. They have difficulty doing their homework or just even reading a book. So these are major life-changing conditions. And these long haul symptoms occur about a month after, or they occur after the acute infection, and they have to last at least a month to be called long COVID. So these are really having significant effect. How common is long COVID? In adult series, it's estimated that somewhere between 30 and 50% of adults who get infected with this virus get post-COVID. In children, the estimates are 10 to 20%, but we don't really have all that good numbers because these are very non-specific symptoms. So you can see it would be hard to know, are these due to COVID or something else? We also know that people who require intensive care for their treatment can end up with a post-ICU syndrome where they have weakness, their muscles have atrophied, they also have this disturbing brain fog, and they may have post-traumatic stress disorder. So that alone and all of the other things that COVID does are a good reason to try to prevent it. And we have the ability to prevent this disease. We have COVID-19 vaccines. They're safe, they're effective, and they're free for everyone. We want everyone to know you can get this whether you're insured, uninsured, documented, undocumented. It doesn't matter. You walk into a site that has a vaccine, you ask for it, and you should be able to get it. So what are the vaccines and which ones do we have available in the US? Well, we have 2 messenger RNA vaccines, the Pfizer vaccine and the Moderna vaccine, and 1 adenovirus vector vaccine, the Janssen vaccine. So let's talk about them a little more. The Pfizer vaccine got its emergency use authorization back in December of 2020. And it was at that time authorized for ages 16 and older. In May, on May 10th, that emergency use authorization was extended down to ages 12 to 17. And in mid to late August, on August 23rd, Pfizer got their full biologic licensure. So they are a licensed vaccine. They are licensed for ages 16 and older for 2 doses. Their booster is under an EUA, and I should have actually added that. That EUA just happened recently, and it's for a booster dose for people 18 years of age and older. So the booster still under emergency use authorization for 18 plus. The Pfizer vaccine fully licensed for 16 plus for the first 2 doses. The Moderna was authorized in the middle of December for ages 18 plus. They have submitted their data for children down to age 12, but they're not yet authorized for them. And they're also working on a booster for the Moderna. The booster is going to be a half dose, so they're still submitting that information. The adenovirus vector vaccine is the Janssen vaccine. It was authorized at the end of February. It's for ages 18 and older, and it currently is a single dose vaccine, although they also are getting information on booster doses and are submitting that to the FDA. AstraZeneca is another adenovirus vector vaccine. It's available globally through most of the world, but it's not available in the US. So let's talk a little about how these work. Okay, for whatever reason, my slide doesn't work. There we go. Oh, my battery is running low. Let me just plug in my computer here. There we go. The messenger RNA vaccines, here's how they work. You take that messenger RNA, which is simply a code. It's a code for protein. It tells your body's cells how to make a protein. In this case, the spike protein that sits on the outside of those coronaviruses. This code, this messenger RNA, is put into a little piece of fat, a lipid nanoparticle. That fat allows the messenger RNA to get into your cells. Once it's in your cells, the code is read and spike protein is produced. That spike protein is then present on the outside of those cells and in the interstitium. And the body says, wait a minute, this protein is not a human protein. I need to make an immune response. And it's both an antibody response and a cell-mediated immune response. These are 2-dose series, and it's not maybe boosters. It's yes, a booster for Pfizer, and soon it's likely there will be a booster for Moderna as well. Now, the J&J vaccine is a little bit different. It's still the code for that spike protein, but this time, instead of it being put into a fat particle, it's put into an adenovirus vector. And that adenovirus is a human adenovirus that's been changed so that it can't make you sick. It can't multiply within your body. So it's a replication incompetent virus. The adenovirus, though, does get into the cells, and then it releases that code. The code is read, the spike protein's made, and the immune response follows. Currently, this is a single dose, but they are testing boosters. They've shown if you give a second dose 2 months after the first dose, you can enhance the immune response. And if you give it 12 months, it actually enhances the immune response just as well, maybe even better. So what are the side effects of these vaccines? Well, for the messenger RNA vaccines, the most common side effects are it hurts where you got the shot, you have fatigue, fever, headache. These are just common side effects from any vaccine. But we know that there are more instances of severe allergic reactions to this vaccine than we have seen with prior vaccines. We also know that side effects are less common in people over 50 and more common after the second dose. So let's talk about these serious side effects of anaphylaxis. So it was realized pretty soon after these vaccines were released way back in February, that there were more cases of anaphylaxis with the messenger RNAs than we expect with other vaccines. So there were 11 cases per million doses of Pfizer and 2.5 cases per million doses of Moderna. And normally we would say anaphylaxis occurs about 1 in a million doses of other vaccines. Now, these reactions occurred within 15 minutes in most cases, and certainly within 30 minutes. Interestingly, most of the cases were in women, and almost all of the people who had this reaction had a history of allergic reactions to other things. So they carried an EpiPen. They were allergic to other medicines and occasionally to other vaccines. So because of this, we had to ensure that all of the places that gave vaccine knew how to handle anaphylaxis. So they had to have epinephrine available in the preformed syringes, those EpiPens, and they had to understand and recognize what anaphylaxis looked like so they could treat it quickly. They also were observing patients for at least 15 minutes and longer if there was a history of allergy. Then they treated the anaphylaxis with intramuscular epinephrine, and they instructed people to seek care if they developed any signs of allergic reaction. And then, of course, all of the adverse side effects need to be reported so that this can be monitored. The next thing that came up in April of 2021, so this was about 4 months after these vaccines were in use, was that there were increasing reports of myocarditis and pericarditis. So this is an inflammation of the heart muscle and an inflammation of the sac that the heart muscle sits in. It was seen just following Pfizer and Moderna, mostly in adolescents and young adults, almost all males, and it was more common following the second doses, about 3 to 5 days after the second dose. The good news is that the vast majority of people responded very well to medications and recovered very quickly within 24 hours. So this is very different from the myocarditis that you see with a viral illness or the myocarditis that you see with SARS-CoV-2. So they presented with chest pain, and their blood test showed that their heart muscle was involved, but they responded very quickly and recovered completely. The CDC looked at all this information. They have a special group that looks at vaccine safety, And they said the benefit of these vaccines outweighs this unusual and rare complication. So they recommended that the vaccination be continued for everyone 12 years of age and older, and they have continued to monitor this. So what are the serious side effects of the adenovirus vector vaccines? Well, the common side effects are those same, achy, it hurts where you got the shot. They're less common in people over 60. And because it's a single dose, those minor side effects are also less common. The serious side effect is thrombocytopenia and thrombosis. So thrombocytopenia is a low platelet count and thrombosis is a clot. So some people who get the Janssen vaccine develop, in addition to develop an antibody against the spike protein, they develop antibody against this platelet factor 4 heparin-induced thrombocytopenia antigen. And if you have antibody against this, your platelet count gets low and you have clots. And unfortunately, these clots are in significant places, covering the brain, in the lungs, and in the abdomen. There was a single case noted during the original studies, and then 6 additional cases noted between the end of February and April. And because of that, there was a pause put on using the Janssen vaccine. These cases had an onset about 1 to 2 weeks after vaccination, which was when you would expect if it's an immune-related problem, because that's how long it takes for you to make antibody. So they paused use of the J&J vaccine in the middle of April, reassessed it, looked for more evidence of this complication. And what they found was this was a very rare complication. And again, the benefits of the vaccine outweighed this rare complication. But they did recommend for anyone who gets J&J vaccine, you need to seek medical care urgently if you have any of these symptoms: headache, shortness of breath, chest pain, leg swelling, gut pain, or those petechiae, easy bruising, tiny spots under the skin that suggest that your platelets aren't working. They made this information available to healthcare providers so they would know how to treat it. And in this case, you treat it with IVIG, gamma globulin, to block those platelet antibodies rather than just with heparin to take care of the clots. The other thing that was noted following the J&J vaccine, in July, it was appreciated that there were more cases of Guillain-Barre Syndrome. And this is a neurologic problem where you have weakness which starts in the feet and moves upward. So there were more cases of this reported after the J&J vaccine than the expected background rate. So remember, there's a background rate of disease, somewhere between 3,000 and 6,000. And after 5 months, about 100 cases have been reported, and they felt that that was somewhat over the background, and therefore they added a warning to the Janssen fact sheet, and that was added in the middle of July. Now, a lot of people have questioned whether these vaccines do anything to fertility, and I'm happy to say that there's absolutely no evidence of any effect on either male or female fertility. There's no biologic reason to expect it. There's no clinical evidence of it. And the American College of Obstetricians and Gynecologists strongly recommends the vaccine for all eligible people who may consider future pregnancy, as well as all people who are currently pregnant and anyone who's breastfeeding. So these vaccines are recommended for everyone 12 years of age and older, and there's no evidence that there's effect on fertility. And what's really changed the game for COVID-19 are the variants. Variants are changes in the virus that arise as the virus multiplies. This happens with every virus. And in this case, in SARS-CoV-2, there are variants of interest that might make people sicker, variants of concern that clearly make people sicker, and then there are variants of high consequences, which we haven't yet seen. The variants of concern are that alpha variant that arose in the UK and was circulating in the US, and I'll show you a graph. The beta variant from South Africa, the Delta variant, which has really taken over, is far more transmissible than the alpha variant, but doesn't necessarily cause more severe disease, but it's just more highly transmissible, and the Gamma variant, which arose in Brazil and Japan. So here's what's happened with the variants. This is a graph from the CDC on the left, and what it shows is from June through September. You can see back in June, there was an equal amount of Alpha variant and Delta variant circulating, and a little bit of other stuff. And then the Delta variant has really taken over and is almost the only thing circulating. Same thing happened in New Jersey, but our information goes all the way back to December. So initially, by January, we were beginning to see the Alpha variant. It peaked, and we had mostly Alpha variant, and then the Delta variant came in right about the end of May, and bam, it just took over, so that recently almost 100% of our isolates in New Jersey are the Delta variant. The Delta variant makes it even more important to get people vaccinated. So how do we do it? We have a call center. You can call this number, 855-568-0545. There are people answering the phones all the time. There are literally hundreds of them answering the phone. They speak a variety of different languages, and they can give you all the information about the vaccines, about boosters, and about other things. In order to get an appointment, you can go to the covid19.nj.gov /vaccine website, and you go to this little button, NJ Vaccine Appointment Finder. It will tell you all of the vaccine distributors near you, which vaccines they have, and what their hours of operation are. So how are we doing as far as getting vaccine to people in New Jersey? We've administered over 12 million doses in New Jersey, and we have fully vaccinated 5.8% of the people in New Jersey. About 84% of our population has received one dose, and 74% are fully vaccinated. So those are great numbers, but we need to do even better. And right now, here's the group that we need to do better with: the 12 to 15-year-olds and the 16 to 17-year-olds. We're doing exceedingly well in the 65 to 79-year-olds. 99% of them have gotten one dose, and more than 90% are fully vaccinated. But if we go down as you get younger, people have been slower to get the vaccine. Now, remember, the vaccine wasn't available to them as soon, but this is this group, these 12 to 15-year-olds who are in school. We want to keep them in school, so we need to get this rate higher. The bubbles at the bottom show third doses. We can't distinguish the third doses because you're immunosuppressed from the booster dose that you would get if you receive Pfizer vaccine. So a lot of people are asking, well, what's better, natural immunity or vaccine immunity? If I already had COVID, why do I need a shot? And I'll tell you, for this, there are more unknowns than knowns, and the more articles you read, the more you can find some that favor vaccine immunity and others that favor natural immunity. So the answer is, we don't totally know. We do know natural immunity is solid for at least 3 months, probably much longer. And we know that vaccine immunity, as long as they've been following it, we're now up to 9 months, and it's solid against hospitalization and death. We also know that against the current known variants, vaccine immunity is great. Natural immunity appears to be pretty good as well. But the other thing we know is, if you have natural immunity and you get the vaccine, you will boost that immunity. So vaccine is recommended even if you had natural disease. What about booster doses? Booster doses are for Pfizer only, and you get them 6 months after your second dose, and it's only age 18 and higher. The recommendation is that a booster dose should be given to people age 65 and older, to people who are 18 and older in long-term care, and to people 50 to 64 who have underlying medical conditions. These are people more likely to be hospitalized, more likely to die. The vaccine booster may be given to people 18 to 49 who have underlying medical conditions. That 20-year-old with cystic fibrosis may choose to get this vaccine booster. And it may be given to people between 18 and 64 who are at increased risk of exposure because of where they work or where they live, the institution in which they live. So these boosters are now available. They've been available in New Jersey since Friday night. And we're strongly encouraging you, if you're eligible and you're in that should category, go get your booster right away. If you're in the may category, consider what your own risks are and what the benefits of getting the booster are, and make your decision in that way. I want to finish with safety at school. We need to have a multi-layered approach to keep our children safe. We need masks for everyone while they're indoors. And those masks have to be over the nose and the mouth. They should be relatively close fitting. They should be clean and dry. We want children to maintain 3-foot distance from each other and from their teachers. We want everyone who's eligible to be vaccinated. The younger children who aren't eligible should be taught in cohorts, so they stay in a single group. So if one child gets sick, you only have to quarantine the people who are around that child. Contact tracing is incredibly important. Infected people need to be isolated and out of school. And then quarantine is for unvaccinated close contacts. Different health departments are using different definitions for when you need to quarantine. And you should check with your local health department for these decisions at your school. So that's the end of my presentation. I just want you to help us spread the word that the vaccines are here, they're safe, they're effective, and they're free. And I'll stop at this point. I probably went a little overtime, my apologies, but let's get on to Shilpa's presentation. So let me stop sharing.
So Meg, before you jump off, again, thank you so much. And I just to let everybody know, Meg and I have known each other for quite a while, and she has been one of those people that most pediatricians go to for these and any other infectious disease question for many, many years. And it's always an honor and a privilege to hear her speak. So a couple of questions came up. The first is, are there any studies on the impacts of maternal vaccination, short-term or long-term, on breastfeeding?
Not that I'm aware of. There's no biologic reason to think that vaccination would have any kind of negative effect on breastfeeding. We know that the antibody that a mother makes does go into breast milk and is transmitted to the baby. We don't know how effective that vaccine is, but we also know that it certainly doesn't do any harm.
The next question is, which I answered, but I want to just confirm because you're more up to date than I am. Mixing vaccines. So if you had a Pfizer, my understanding is you have to stay with Pfizer. You can't get Moderna or J&J. If you had J&J, you stay with J&J. That is correct.
That is correct as of this day in September. Okay?
Exactly.
We're still in September. So there is a study going on. It started in June, and it is a mixing and matching study, but we don't have those results yet. So the current recommendations are you stay with what you have. There is one exception. For immunosuppressed patients who need a third dose, if they go to a center and the dose, if they got Pfizer or Moderna and they need a third dose, and they go to a center that only has Pfizer or only has Moderna, they can get whatever's available. But that's the only exception to the rule.
Okay, and one last one. There have been many discussions recently about women having menstrual changes, breakthrough bleeding, et cetera, after the vaccination. Any thoughts, comments on that?
Yeah, I have certainly heard that. I have not seen a study that actually quantifies that. I think we all know that women's menstrual cycles are pretty fluky. They, change with the wind. When somebody's stressed, one of the first things that happens is your menstrual cycle goes a little bit out of whack. And for many people, getting the vaccine is stressful. So I guess it wouldn't surprise me all that well. I don't think it's necessarily vaccine related. It may be more stress related. And goodness knows right now, we are all stressed to the max. There is no evidence that there's any long-term effect on fertility or on any reproductive health issues.
Thank you very much, Meg. As always, it's always a pleasure to listen to you talk. I always look for your YouTube videos because they're excellent.
Thank you.
So for everybody out in the audience, you can find many of her talks on YouTube. Not this one yet, I don't think. But as she said at the beginning, if you watch her videos, make note of the date, because the one she did this time last year is woefully out of date, and this may be out of date by Monday. So stay tuned. And with that, I'll turn it back to Robin. Robin, you're on mute.
Thank you. I said make sure you watch this tomorrow because it will be available on the website. It is my pleasure to introduce you to our next speaker, Dr. Shilpa Pai. She's an associate professor of pediatrics at Rutgers Robert Wood Johnson Medical School. She's the founder and director of the Resident Education, Advocacy, and Community Health Programs for the Pediatric Resident Physicians and co-director of the Health Equity Thread curriculum for the medical school. She also practices pediatrics at Eric B. Chandler Health Center, which is a federally qualified health center right here in New Brunswick. On the state level, she co-leads the Adverse Childhood Experiences Rutgers Project ECHO and co-chairs the New Jersey Academy of Pediatrics Immigrant Health Committee, as well as serving as a special state officer for the New Jersey WIC Advisory Council and founder and co-lead for the New Jersey Pediatric Residency Advocacy Collaborative, which is a grant-supported organization that brings together all 9 pediatric residency programs to improve residency training through advocacy and community health. Nationally, she serves on the AAP Community Advocacy Resident Education National Leadership Group and is a District 3 Community Access to Children's Health Facilitator. Her research interests, which you'll hear about in about 2 seconds, are adverse childhood experiences, social determinants of health, immigrant health, and food insecurity. It is a privilege to introduce Dr. Shilpa Pai. Thank you.
Thank you, Robin, and thank you, Meg. And that is such a tough act to follow. That is my one complaint, is to go after Meg Fisher is going to be tough. So I don't know if anyone just, if you want to stretch while I start talking. Let me pull up my slides. Give me 1 second. All right. I'm hoping you can all see my slides. Robin, can you just confirm?
Yes, we're good.
Okay, great.
Thank you.
So just going to pivot a little bit, but I really wanted to just kind of share from my experiences in working at a federally qualified health center and from my experience in terms of working in an underserved community specifically about how we've seen 3 different pandemics collide. That means health inequities, racism, and COVID-19. I do apologize in advance. I just want to give some disclaimers that I am attempting to cover a lot of topics. I don't feel comfortable taking out any of these topics because I feel like they're all coming together. And I also want to say that just kind of some of these topics that I'll be talking about might be a little bit triggering for people. So feel free if you need to take a pause from this presentation. So our objectives for today is we're going to talk about social determinants of health, implicit bias, and how structural racism leads to health disparities, and recognizing how that's come into play around COVID-19. And finally, I think this is the most important part of the presentation, is really talking about what can we do for solutions and mitigating these effects. So first, let's talk about health disparities. So what is the difference between equality and equity? And I want to make this as interactive as possible in a 145-person audience. But if you can put in the chat about what is the difference between the two. When we talk about health equity versus health equality. Great, thank you. Equality is giving everyone the same resources. And what would equity be? Equity is far better. Thanks, Meg. Yes, so equity is what we're aiming for, right? So it's important to recognize that, especially as we think about who experiences more of these burdens, right? So thinking about who has a different health outcomes, because different people are going to have different needs. So there's no one size fits all, right? So you look in that equality picture, which I really appreciate, it's just having that one solution for everyone, but that's not necessarily the right solution. Whereas equity is really talking about tailoring that solution to fit the person's needs and recognizing that who experiences more of the burdens, right? We talk about those who have illnesses, injuries, disabilities, and how that's going to have an effect on mortality. That said, I think it's important to recognize who are the most vulnerable. So the most vulnerable. So as I talk about these populations, if you can put in the chat, who are these people? Vulnerable populations can be those difficulty communicating. So who's that? Who are those that have difficulty accessing medical care? And you can put that in your chat. And who has difficulty maintaining independence? Again, we can put those in the chat. I'm going to read some of these. Immigrants. So yes, absolutely. So I'm trying to go through this. So I just want to highlight Chanel's comment. Health equality assumes everyone has the same. Equity is understanding everyone's differences and that impact on access. Thank you. That's great. It's a lot better than what I just said. So talking about who are the vulnerable populations. So we're talking about difficulty communicating. So those can be with those with language barriers, accessing medical care, uninsured, impoverished, socially isolated, needed help maintaining independence. People with cultural differences may have difficulty accessing medical care and communicating, lacking technology, all great suggestions. Seniors, I'm missing one big group. I'm a little bit offended that I'm not seeing them in this group. As a pediatrician, children, right? So that's a big one. So a woman and children, right? This is what you guys do. So it's really important that we recognize who are these people, right? And obviously we're missing a lot of people too that I haven't mentioned, but recognizing it's people that we work with on a regular basis, people like ourselves. That said, who are the socially disadvantaged? So, and I'm going to get more into this, but we're going to talk about it around different sectors. So race, ethnicity, gender, education, income, ability, geography. I think this is something that we don't talk about as often. I think, even in New Jersey, right? Thinking about rural areas, also urban areas and access to transportation, and then sexual orientation and identity. So why does this even matter? I'd like to think that we all care about equity. I think right now I'm preaching to the choir when I talk about equity, but unfortunately not everyone does. For a lot of people, when we talk about the upstream people, the people that are making a lot of these decisions, it's cost, right? So talking about money, and money talks a lot. So $93 billion could be saved if we actually made these changes around social determinants of health, because when people get sick, it costs a lot of money and they can't work. So then we're losing money because they're not $40 billion worth. And then when they are sick, they're dying earlier and they cannot contribute to the economy. And it's also important as we think about this increasingly diverse population, and this slide just demonstrates how we are becoming more and more diverse and how we need to recognize the needs of our diverse communities and make sure that we are serving those different populations. So what contributes to these health disparities? A lot. We can talk about it in terms of individual behaviors. And I think it's too often when we talk about individual behaviors, we're kind of placing the blame on the patient. But I really want to talk about it more in terms of social determinants of health, implicit bias, and then the health effects of racism. So let's talk about social determinants of health. So you guys all know this already, and I know Robin alluded to this in her presentation in the beginning. It's recognizing that where people live, learn, work, and play has a significant factor as we talk about what contributes to their health. More importantly, I talk about this, well, I'll get to this in a moment, but it's important to recognize this as I have an inpatient interaction. So I think about this happened to me yesterday, right? So I had a patient, if I have a patient that comes in, they have poorly controlled asthma, 10-year-old with poorly controlled asthma, not taking their preventive medication, Flovent, which prevents their asthma from acting up. And I told this mom a few months ago, I said, why, that the child needs to be taking the Flovent, because that's what's going to prevent the asthma from acting up. But the patient's not getting the Flovent. Why? So is there economic instability at home? Mom doesn't have her, lost her job. She can't pay for the copay to pay for that Flovent. Or is it her environment that she lives in? Does she not have a car to get to the pharmacy to get that Flovent? Or is there education? Maybe she can't read the instructions on that, and therefore is not giving the medication the way it's supposed to be given. Is she food insecure? Are they family food insecure? So mom has to make that decision. Do I pay for food or do I pay for the medication? Or is the context in which she's living? Is she does not feel like she has the support systems? Or is it just the healthcare system? Did I just not do a good job explaining what this medication's for? Or do I speak a different language than her? And then she doesn't understand what the medication is needed for. So thinking about that, it's important that, and this is my favorite slide to show to medical students and residents, because even though we're going, after 4 years of college, 4 years of medical school, 3 years of residency, and umpteen years of experience, I think it's important and humbling for us for me as a pediatrician to realize that only 10% of what I'm doing in that encounter, that office encounter, has an impact on a person's health. So it's important to recognize what's going on outside that office. So when that patient leaves my office, what happens? What happens when they can't get to that pharmacy? What happens if they can't read that prescription? What happens if they have other things going on in their lives that's going to have a bigger impact on their health? And what can we do to ameliorate that? So it's important as we look as what happens when a patient goes outside, and what play does that have? So I just want to talk about a snapshot of some of the research that has been done. And there's been a lot of research done. So unsafe neighborhoods, right? And thinking about that in the context of social determinants of health. So again, if you can put in the chat. So if a person is going through multiple moves, overcrowding, and physically inadequate housing, that is going to lead to poor health outcomes. So what are some of those poor health outcomes? If a person lives in an impoverished neighborhood and they have fewer parks or green spaces, what are some of the poor health outcomes that's going to lead to? And now let's think about it in terms of unsafe play spaces and not having access to recess, physical education. What poor health outcomes is that going to lead to? Great. So we're talking about living in crowded spaces can lead to asthma. Poor air quality is asthma. Obesity. That is something, as a primary care pediatrician, I have seen lots of obesity, anxiety, and depression. So all things that you guys are alluding to: lead exposure, depression, anxiety, crime, right? We're talking about, how about gunshot wounds? Something that we see often. We're seeing a rise in gunshot injuries. No social skills. Oh, great, Jamie, thank you. Easy spread of contagious disease. So what did Dr. Fisher just speak about? COVID, right? So a lot of times when we talk to our patients about social distancing, about if they're infected, they need to socially distance from the rest of their family. That wasn't an option for many of my families. They couldn't be in a separate room because they had 5 people living in a room. So that was just not an option. So it's important that we recognize that, especially when we talk about it in terms of social determinants of health and its impact on real life health outcomes. Food insecurity. So with food insecurity, we see higher rates of obesity. I like to tell the story about when I just finished residency and I was working in West Philadelphia, and I knew it all. I finished 3 years of residency. I just passed my boards. Of course, I knew everything about pediatrics. And I had a mom who brought in her 2 obese kids. And it was in the evening clinic because it was right after she finished her 1 job and on her way to her 2nd job. And I said to her, so I'm like, in my head, I was like, okay, I can do this. I know I'm going to convince her how to eat, give her child more healthier foods. So I said to her, where did your kids have dinner tonight, for example? And she said, oh, we just had I picked up some Happy Meals before we came here for their appointment. So again, I was like, okay, I can work with this. Let's meet I'm going to meet her halfway. So I said, so when you go to the McDonald's, you got Happy Meals, but instead, why don't you get them a grilled chicken sandwich or a grilled chicken salad? That's exactly what I said. Because that's healthier options. So what do you think she said to me? So she just, gave me that look, and she was like, well, if I get them that grilled chicken sandwich, let's see if you guys are a lot smarter than me, which I'm sure you are. Too expensive. Absolutely. Right. So she said, how much does that Happy Meal cost? And at that point, she said it was like $1.99. And she said, how much does that grilled chicken salad cost? And she said, well, that's $4.50. So I was like, oh, okay. And then, thank you, Trish. She said, and I don't even know if my kids are going to eat it. Right. Because that's something that they might not like. And then more importantly, they might not, you guys are much smarter, Cheryl. They might not be full after that, right? And Happy Meals taste so much better, all those things. So again, I can speak all I want in that office setting about, oh, it's really important that you feed your child healthy foods like salads and quinoa, tofu, right? But thinking about what are the costs differential, what will they eat? And also being culturally aware about what is within their palate, right? So all these things are super important. And what's in there, I didn't even touch upon being in a food desert. What kind of grocery stores are available to them? And affordable. So just touching upon the social determinants of health. And again, now I want to just touch upon how implicit bias affects the care that we receive. So what is implicit bias? So I'm sure many of you have heard of this term before. So implicit bias, it's important to recognize that, I'm sorry, I'm just reading through your chats because it's really, and plus you get a toy. Love that with a Happy Meal. You don't get that with a salad, that's for sure. So implicit bias. So I'd like to think that none of us have implicit biases, but we all do. We're humans. That's how we navigate life, right? We have to have these biases because it's going to just, how we have these as we have just in our regular interactions. But I think one of the things that we need to recognize is that when we have these implicit biases, it runs contrary to what we might think that we feel. And it's dangerous when it affects how we treat others. So there is this test called the Harvard Implicit Bias Test. And it's a way to kind of recognize that what biases you may or may not have. It's really just to raise awareness. So I just, again, want to talk about my own personal experience with implicit bias. So my implicit bias is against teenage boys. In full disclosure, I have a teenage boy at home. I have a 16-year-old boy at home. So I think that has a lot to do with it. But when I have a teenage boy on my schedule that I'm going to see in my office, I automatically think, oh, this kid is not going to want to talk to me. This kid's going to be one-word answers. It's not going to be a fun visit. He's just going to, he's not going to be interactive. He's not going to care. And I go in with that mindset when I have that 16-year-old boy in my office, right? So just imagine when I'm going in with that mindset, what my body language is, what my eye contact is going to be with this kid. Am I, my arms folded? Am I have my back to him? Am I asking him brief questions, not really listening for his answer or waiting for his answers? So what kind of therapeutic relationship is that going to be when I go in to that visit? So implicit bias exists throughout all different fields. I'm just going to talk a little bit more in the healthcare setting and how as physicians, we have a lot of biases and studies that have just supported that. So there is implicit bias amongst those with different weights, specifically against overweight people. Gender. They're in the field of orthopedists. Orthopedists are more likely to recommend knee replacement surgery more for men than women. Any idea why? Well, men are thought to be more active. So that's why they need that knee replacement surgery as opposed to women. Similarly with cardiologists, cardiologists are more likely to recommend angiography. So a test to just to kind of open up their arteries for females versus men, because men, they associate that more with risk taking and again, more active and more so therefore more useful for men. Sexuality. Healthcare providers have an implicit preference for straight versus gay people. But what I want to talk about, again, I'm touching upon these different topics, all which are very important, but I am going to be focusing today's talk on talking about race. And has gotten a lot of press recently. And again, we're going to delve a little bit deeper into this. So implicit bias and race. Again, some of this might be triggering for many, so I just wanted to lead with that discussion. So back in 2012, there was a study that showed that Black patients are 20% less likely than white patients to receive appropriate or any pain medication. A more recent study by actually Monica Goyle, who was one of my medical students, back in May 2020, so recently. I want to stress the timeline because this is now. This is not something that happened in the 1950s, 1960s. This is happening now. Minority children, when they're coming into the emergency room with a long bone fracture, are less likely to receive opioids and receive optimal pain management. So you have children who are in pain, but because they're Black, they're less likely to receive appropriate pain control. And these experiences in pain compared to white people. So Black people have felt that they have had their pain underestimated, less comprehensive diagnosis, and less access to pain medicines. So it's this interaction that we're seeing. I like this diagram because it just demonstrates how patient factors such as coping and perceived bias, so recognizing that they are being discriminated against, and then the expectations that they may have, then the provider coming in with their implicit bias, and then the systems factors, right? So we're talking about access to care and how that's going to lead to poor therapeutic relationships. More about implicit bias and race. So I talked about pain management, which is one of the hot topics. But however, we see that Black individuals, and I'm going to be talking about implicit bias and race along the lines of Black races, and talking about Black individuals are more likely to be undergoing lower limb amputations for diabetes, less likely to get home dialysis. In the world of psychiatry, Black individuals are more likely to be diagnosed as psychotic, but less likely to be given the appropriate medications, more likely to be hospitalized involuntarily, and more likely to be regarded as violent and placed in restraints. Again, more recently, our pediatric surgeons and anesthesiologists, they did a study recently, 170,000 kids. Black children were 3 times more likely to die within 30 days after surgery. And this is taking into account any kind of illnesses they may have had before. And unfortunately, this starts early on in our students and medical students and our trainees, our pediatric residents, all our residents, that there is that myth that many medical students felt back in 2016 that Black people had thicker skin than white people and therefore experienced pain less. And I want you to think about this, right? So I talked about my own implicit bias. So now imagine that patient comes to that, right? That visit, and they recognize my bias, right? And remember, we all have implicit biases. And I just had a patient the other day who told me they don't like Indian doctors. So just imagine that. So imagine that patient who said they don't like Indian doctors comes to me and, and has that teenage boy that I, have my bias against. And now think about what kind of therapeutic alliance are we going to have? It's going to be pretty bad, right? Because we're coming in with our negative biases. I might think because he's a teenager, I don't think that he's going to be not take his medications. He's not going to take that Flovent, which I mentioned earlier, because he doesn't care, right? He's such a concrete thinker that he doesn't care about his health. So I'm not going to give him that medication because I just assume that he's going to be quote unquote non-compliant. And then that's going to lead to poor health outcomes. And it's important that we think about this, especially how race comes into play and the factors that leads to, especially around racism. So as a pediatrician, I have to quote our AAP president, Dr. Lee Beers. We are always learning and striving to provide better care for all of our patients. Using race as a proxy for biology or genetics can lead to inequitable care and outcomes. So basically, coming down to that race, it's a social construct. It's not a biologic issue, right? So there is no difference that we learned in my medical school training back in, early 2000s. Early 2000s, late 1990s, that I didn't learn anything that my biology is any different than a white person's biology, any difference from a Black person's biology. But it's really about thinking about what's going on outside. So I do want to touch upon adverse childhood experiences. And I'm going to bring this together, I promise. So adverse childhood experiences, which I'm sure many of you are familiar with, is a study done back in the late 1990s. So there was two physicians, Dr. Anda and Dr. Felitti, out in California, who were running an obesity clinic. And with that obesity clinic, they happened to ask their people that were being seen there, you know, what happened to you when you were a child? Were you ever physically, emotionally, or sexually abused? Were you ever neglected, either emotionally or physically? Or was there a lot of household dysfunction in your family? So were there people who had mental illness? Did you see your mom treated violently or abused? Was there substance misuse? Was someone in jail? Was there a divorce, a single parent household? What was going on at your home? And they did this, and then they found a lot of people who were in this obesity clinic actually answered yes. So they broadened this study to over 17,000 participants, and they worked with people from Kaiser Permanente, CDC, University of Arizona, Emory University, and they started tracking these health outcomes in adults and what happened to them as children. And what they found, that the more ACEs, or the more of these adverse childhood experiences they had, the more likely they were to have negative health outcomes, and that magic number being 4+ ACEs. That said, if an adult had 4 or more ACEs, they were 200% more likely to be diagnosed with arthritis or asthma, 400% more likely to get chronic obstructive pulmonary disease. Anyone want to guess suicide attempts? You can put that in the chat. Let's read on. 200% more likely to have a heart attack, almost 300% more likely to have a stroke. How about suicide attempts? Anyone? Look in the chat. Someone, Jocelyn says 200% more likely, 400, 500, keep going higher. 1,000% more likely to have a suicide attempt. But after we learned about adverse childhood experiences, in Philadelphia, there was another study that came out in the early 2000s about adverse community experiences. So we talk about what goes on in their home, but what goes on when they step outside that door, right? So what happens? Are they experiencing food insecurity? Are they experiencing racism? Are they experiencing bullying, poverty, community violence, poor academic performance? So what's going on outside? So specifically, let's talk about racism. So adverse childhood experiences, right? So we're taking all this into play. So when you have that child that comes in that may be abused, seeing their mom being physically abused, treated violently. So now you have one ACE that they're abused. They're seeing their mom being treated violently, and maybe there is a sibling in there who has a history of drug use, right? And then they're living in poverty. So now you have 4 ACEs. Now just think about that child. Think about the kids that you work with on a regular basis. Thinking about the women that you work with on a regular basis. Think about yourself. Think about a family member. Think about a friend. And just think about that stress that that child, right, who has those stressors may feel. They can't turn themselves off. They can't calm themselves down. Their adrenaline levels are through the roof. Their cortisol levels are through the roof. And then those first 3 years, when that baby, a 2-year-old, is seeing this on a regular basis, on a daily basis, worried about being abused, worried about not having enough food to eat, think about how that's going to affect their brain development. They can't calm themselves down. Their brain has been affected. Their brain has been changed. And if you look at PET scans of babies who are raised in orphanages and that a child of a PET scan of a healthy brain, a healthy child's brain, look at the differences. And you don't need to be a radiologist to recognize where is the activity levels, where is the lack of activity levels in the abused brain, and what that's going to lead to. That's going to lead to lack of control, lack of being able to regulate themselves. And that comes in together when you look at a child and looking at that perspective of what goes on at home and what goes on outside their home, and how those things come in together, specifically as how that child develops. So now that child that we talked about with those 4 ACEs has that disrupted neurodevelopment. So we're in the red now, right? Now that child starts school. Now that child is in kindergarten. That child has never learned how to cope. That child can cope because of the stress hormones in their brain, the way their brain has now formed. And now they're labeled as that bad kid when they start in the school system because they don't know how to socially navigate. They don't have the emotional intelligence. So they're the bad kid, right? They're going to have that label. Now they're in middle school. Maybe now they've discovered marijuana as a way of coping, and that's how they self-medicate. And that's how they deal with their impairments. And marijuana doesn't work. Maybe they start going over to heroin, IV drug use, and smoking cigarettes. So we all know that's going to lead to poorer health outcomes, chronic obstructive pulmonary disease, hepatitis. They can't maintain a job. They can't contribute to society. And eventually that leads to an early death. Now we need to talk a little bit about New Jersey. How are ACEs in New Jersey? So nearly half of all people in New Jersey experience at least one ACE. Children living in lower income backgrounds and of color are more likely to have ACEs. A quarter of those being Black children, a quarter being Latinx children, and 16% white. And as Robin already alluded to this, we're going to talk a little bit about infant mortality. So as New Jerseyans, we should be very proud of ourselves. We have one of the lowest rates of white infant mortality in the country. We can pat ourselves on the back. And same amongst Black infants too, one of the lowest. But as Robin pointed out earlier, we have a huge disparities, one of the highest disparities. Black infants are 3 times more likely than white infants to die during their first year of life. So why do we have this disparity? What is the biologic difference that between Black infants and white infants that Black infants are more likely to die? There is no biologic difference, but we need to kind of take a deeper dive into seeing why is this happening in one of the wealthiest states and the wealthiest countries in the world. Preterm birth rates. Again, Robin talked about this, that Black infants are more likely to be born preterm. So let's take this deeper dive. Again, I know I'm covering a lot, but I just want to explore all these different topics. So the CDC reports that Black women are more likely to die from heart disease, more likely to die from cervical cancer, 70% more likely, and 200% more likely to die from anti and postpartum related causes. And that comes down to cardiomyopathies, thrombotic pulmonary embolism, eclampsias. So all these fancy things, not fancy things, all these complicated things, about heart diseases and MLI and blood clots, eclampsia, which is high blood pressure, can lead to this early death. But why, again, are Black women experiencing this more than white women? Because what happens outside a woman's body, not just during the 9 months of pregnancy, can profoundly affect the biology within. So while I said that there is no specific genetic or biologic difference between Black infants, we have to take into account what happened outside that affected their genome, affected their genes and changed that. So in 2006, there was this hypothesis that came out about the allostatic load. So the allostatic load is looking at what happened on a body system due to these repeated adaptations to stressors. So this is where I like to tie these things in. When we talked about adverse childhood experiences, ACEs. So Black Americans have that weathering, which is that their health deteriorates more rapidly because they have this heavier burden or heavier allostatic load that continuously are wearing on a Black individual's body. And when you combine those with being Black and a woman, we have double jeopardy. So the studies that support this. So we can say, is it, okay, no, it's because of there's something in the Black genome. But they looked at Black immigrant women, so of African and Caribbean immigrants who arrived in the US as adults, and they experienced better outcomes than native-born African-American women. People can say, oh, it's because of education levels. They looked at studies in 2019. Black women with advanced degrees, lawyers, doctors, MBAs, 5 times more likely to lose an infant than a white woman who hadn't graduated from high school. So trying to bring this all together, that we realize that discrimination, racism is a social determinant of health. It is an adverse childhood experience. It is an adverse community experience. Because with that racial discrimination, it can lead to denial of goods, resources, or services. I haven't talked about redlining and zoning and how Black families are less likely to get granted mortgages, because as we know, many of the times just escape from poverty has to do with housing and access to housing. But denial of those mortgages in neighborhoods they have better access to resources, better access to healthcare, better access to education, prevents individuals from leaving that environment. And imagine that discrimination over and over again leads to that psychological stress. Poor living conditions, decreased access to care, decreased access to quality education, the symptoms, coping with that, this response, the physiologic stress response. And this is where we talked about higher blood pressure, the cardiovascular disease, decreased birth weights, and it becomes this intergenerational trauma, intergenerational genomic changes, and mental health changes as well. And all of this kind of blew up during COVID. And Senator Warren, decades of structural racism have prevented so many Black and Brown families from accessing quality healthcare, affordable housing, financial security, and the coronavirus is blowing these disparities wide open. I just want to take a quick look at the chat. Okay. And I'm trying to keep an eye on both, but if someone keep an eye on that chat while I speak, if any comments that come up that need to be addressed.
Will do.
Thank you, Robin. So there's this COVID racial data tracker from out of Boston University, which is just fascinating to read. But looking at, so when the pandemic first started, I remember seeing this slide from April of 2020. Looking at the discrepancy. So in Louisiana, while a third of the population is Black, who was dying, 70% of the people that had died from COVID were Black. Illinois, 15% Black population, but who died, 40%. And in Chicago specifically, 30% versus 70% of those who died were Black. St. Louis, I didn't have that listed there, but St. Louis at one point, I don't know the exact demographics, but I do know at one point in St. Louis, of those who died from COVID, 100% of them were Black. And now looking 2021, this year later, it continues, right? This trend has continued, that who is dying at a highly disproportionate rate. It continues to be Black individuals, followed by those from Native American and then Latinx population. And while Blacks represent only 3% of the nation, they account for 24% of the COVID-19 related deaths. Why? There's a lot of different factors. We can talk about Black individuals not having access, living in areas where they might represent less than 15% of the, living in areas that impoverished areas. And I talked again about structural racism and how that led to people living in more impoverished areas, higher density, more likely to have a pre-existing condition, be an essential worker, and less access to testing. And that's been proven throughout the country. In DC, Latinx populations, highest per capita infection rates. Memphis, Tennessee, 3 testing sites in predominantly Black neighborhood compared to white neighborhoods where more testing sites. Philadelphia, close by, more testing sites in high income neighborhoods. And then 7 states, Black people representing with fever and cough were less likely to receive a referral for COVID testing. And also, who's working and where are they working? Who can telework? Who can telecommute? Only 16% in Latinx workers, 20% in Black workers, and 30% of white workers. So there's a huge discrepancy who can actually work from home. And let's look more at the data to support this. A third of African-American individuals use public transport regularly. So again, this was alluded to Dr. Fisher's discussion and in Robin's discussion. Who's working in the roles of caregivers, cashiers, sanitation workers, public transportation, most likely to be Black, less likely to work in telecommunicating. And there was a quote in the New York Times, one of the headlines in early 2020, that either risk starvation and not go to work and risk starvation, or stay at home risk starvation, or go to work and risk infection. So those are the choices, and that is not an easy choice to make. And I would be remiss not to talk more about children as a pediatrician, but the child mortality rate is reflected again amongst race and ethnic background as well, who is more likely to die, and looking at it in terms of Native American, BIPOC communities. We're talking about Black, Indigenous, impoverished communities of color. And let's talk about economics, because again, unfortunately, money talks. So the job losses, who's experienced the highest number of job losses? 8 million individuals reported food insecurity in 2019. That increased by tenfold in November 2020. 83 million adults reported food insecurity, rent insecurity, car payments, medical expenses. Just personally, I work at a federally qualified health center where I've implemented screening for social determinants of health. Every single day I get an answer of yes, I don't have enough food to feed my child. I don't have enough clothes for my children. Some families have told me that they are scared to tell me that they don't have enough food for their kids out of fear that their child will be taken away from them by Child Protective Services. And this is something I see every single day. I also work locally I serve on the board for the Princeton Mobile Food Pantry, and our food pantry numbers have increased exponentially. People needing food because their parents work in food industry and they can't work in the restaurants anymore. And then they can't afford childcare because they're working, their children aren't in school. So a lot of different factors are coming into play. And who are these people? Who are those communities? So a lot of them are Black and Latino communities. 45% of kids are living in a household where it was somewhat or very difficult to cover these expenses. Again, just talking about how these numbers have just increased exponentially. COVID and poverty, all these things coming together again. Poverty only amplifies the COVID-related risks, right? So we talked about who is most affected by COVID. It's those living in poverty. Crowded housing, like we talked about, more likely to experience underlying health issues because those living in poverty more likely to have obesity, high blood pressure because of food deserts, food insecurity. And then those also talking to my patients and the experiences they've had about their children not having just access to Wi-Fi, and thinking about that as like a basic need. Limited space to play. I've seen so much obesity happening, but when I tell them, why don't you go outside and play? There is no space to play. There's no safe space to play. I say play inside. There's no space to play inside. Those living in single parent households, higher risk of poverty as well, and limited access to childcare assistance. But I'm hoping that we are seeing some changes with universal pre-K. And it only amplifies the ACEs. So I've seen parents who have just been above and beyond stressed. I mean, I can just speak for myself in the beginning, how much sleep I was losing because not knowing how to navigate COVID, right? I think about it in March 2020, that having elderly parents, having kids that were at home being schooled from home, and just, working in the office and not knowing how to control COVID, what to do about it. And just, just concern for not just our children, but our family members, our loved ones, losing loved ones. And with that, a lot of stresses, higher rates of domestic accidents, children trying to cook from home. So we're seeing those injuries. And this is something I struggled with myself, working from home and full-time childcare, and the number of interruptions I would have, and with whether I was doing telehealth and someone asking what's for lunch, which was the mildest of the things, but a lot harder stressors coming along as we tried to balance all these things. And unfortunately, there's been a lot of studies that we've seen that women have experienced the highest level of stresses along these lines, and then only just exacerbating existing mental health conditions. Worse in single parent households, less supervision. Fear if a parent becomes ill, who's going to take care of those children? and that increased isolation that many families experienced because that not having contact with others. And then those who have custody issues, alternating between homes, not seeing some parents, and leading to more conflict between parents. And then, like we talked about, a lot of it is the lack of routine that children didn't experience. And again, all I see day in, day out is the anxiety in children not wanting to go outside their home. Depression, we've seen a significant uptick in suicide attempts in children in our emergency rooms. When people ask me, how have you seen it affect COVID affecting children? And I say, this is what I've seen. It's not, and it's been horrific when you see kids. I saw a 5-year-old just yesterday who gained 50 pounds in a year since the last time I saw them, 50 pounds. And with that, we know all the disease that leads to, and we talk that, and ACE COVID is now an ACE because they didn't have routine. They didn't have access to outdoor activities. They weren't allowed to play in sports. Gyms were closed, parks were closed. A lot of children were just on their electronic devices, increasing screen time, all things that we've been spending years about talking about and trying to give guidance about what not to do. Children didn't have a choice. They had no options. And unfortunately, we've seen higher risks of child abuse. We may think that we've seen less reporting, but that's because there's been less in-person contact between children and child protective services, less reporting of these concerns. We depend a lot on our teachers, and our children not being in schools. Teachers are unable to report that. I mean, you've heard some stories. I heard a story of one of my friends who's a teacher saying how they were teaching virtually and they saw a child being verbally abused on screen by a parent who thought they weren't on screen. Worsening contributing factors about poverty, overcrowded housing, leading to higher rates of intimate partner violence, higher rates of substance use, and higher toxic stress. And all these things, again, vicious cycle, the change in routine, break in learning, break in continuity of healthcare. A lot of my children and patients aren't getting the necessarily vaccines. We've seen a decrease in the number of vaccinations that our children are getting. That lack of missing out on graduations, missing out on proms, missing out on just significant birthday parties, and that loss of security, that uncertainty. And this is a trauma. This is an ACE. Now, going back to recognizing that COVID is an ACE and recognizing that who are those that are experiencing COVID at disproportionate rates. And those are those who have asthma, are more likely to be hospitalized with COVID, high blood pressure, obesity, diabetes, chronic kidney disease, obesity, again, severe obesity. So as you remember, right, for more ACEs and the higher percentage of obesity, higher percentage likelihood of diabetes, higher percentage likelihood of high blood pressure. Now let's look at race and the overlap between race and those chronic diseases and COVID, and who is most likely to be hospitalized and who is more likely to die. I'm not going to read this out to you, but you see that those of Native American were 5 times more likely to be hospitalized. Black individuals almost 5 times more likely to be hospitalized, and 2 times more likely to die. So you see this, how this is all coming together. And this is this intersection of discrimination, racism being a toxic stress, discrimination leading to poor housing, poverty, less access to healthcare access. So we're talking about language barriers, the housing and the education, who's working the jobs where they can or cannot work from home. So I know this is disheartening, and every time I talk about this, I get a little outraged, a little discouraged, but there's optimism. I think I'm so grateful to be talking to you as a group, because you guys are making so many amazing changes and implementing so many positive changes that address a lot of these topics that we're talking about, which are social determinants of health, implicit bias, ACEs and racism, and health equities. So as a pediatrician, there are a lot of policy statements out there that are calling for change. So around poverty and child health, about how racism needs to be addressed and it should be anti-racism, about using inclusive words, anti-biased language. And a lot of this work that's out there that's been done already, but how do we incorporate this? And especially as we talk about race-based medicine and recognizing that race is not a risk factor. And what can we do as pediatricians, as community health workers, as doulas, as early intervention specialists, as nurses in terms of making a change? So let's talk first about social determinants of health. This is one of the things that's very powerful when we talk about the importance of working with community agencies, such as Central Jersey Family Health Center Consortium, and make collaborations. I think it's very, very important to break down these silos as we talk about working with our partners to provide better care for our patients and populations. And talking about it, when we do that at lower costs. I was so excited to hear about, Robin, when you mentioned the home visiting program. And I'm a little jealous because I don't hear about it happening in New Brunswick, but what a tremendous service we're giving to moms in Trenton by providing that service, because we're working with our vulnerable patients who may have access to transportation or housing, and what can we do to improve that and actually address it in a meaningful way. So when we talk about screening for social determinants of health, it's important that we do it in a brief, validated, and patient input way. And most importantly, having resources. So when we do that, and this is something I work with our medical students and residents and my colleagues, it's important that we do it in a sensitive way. Too often I see my medical students sometimes, or my residents, just kind of reading off a list, right? So a lot of times we're not going to get that positive answer because you're giving off the body language that you don't care. And that's why I try to teach to my students and my residents. But it's important that we engage them. It's important that we avoid the stigma. It's important that we really see the patient as a person and getting to know them as opposed to just collecting data, and explain why you're doing this. Too often we ask the questions, but we don't say why we're asking the questions. I found when I framed the question, so I usually, when I'm talking to my patient, and I will tell you a lot of times when I've started asking about food insecurity, it was my resident that pushed me to do that. And I felt uncomfortable because I live in New Jersey. No one's food insecure. Everyone has access to food. But the more I asked about it, when I first started asking about it, I'll be honest, my patients looked at me. They're like, well, why are you why are you asking me this question? And as if I was judging them. And I felt uncomfortable. But as I started asking it on a more regular basis, I found that I said, and, was just saying like, I'm asking this because we ask all of our families this question. People started pausing before they answered. People started, saying, well, yeah. And then I was able to kind of use that as an opportunity to have that discussion, saying, oh, do you get WIC? Or do you have access to SNAP? And said, yeah, but that's not enough sometimes. So it just opened that discussion. And I said, okay, let me just give you some resources. Let me just help, connect you with some organizations that can help provide you with what you need. And that has just been tremendous, because when you shift that conversation and talking about all, what we can do to provide, it's important to kind of talk about it and avoid that stigma. And with COVID, one of the things I've been saying to everybody, I say, with COVID, a lot of us, all of us have been affected by COVID. And talking about a lot of people have lost jobs. A lot of people have had some difficulties. So that's why I ask everyone this. So talking about it and shifting that conversation and reframing it. And I think the other thing is important, though, as we ask these questions, I try to make it a point to also recognize that every family is trying. It is really difficult. I mean, even as a parent who's an educated parent, who I speak English, I am in a dual parent household, I still find it difficult. But yet realizing that many people don't have those benefits, and and it's really hard. And I think it's important that we recognize it's really hard, but also recognize that I try to tell my parents, you are doing such a great job. Just by them bringing their child to that appointment, just recognizing that you're doing a great job, and that it speaks volumes, right? Because in the end, when we have these dynamics, I recognize that I am in that hierarchy, in that power dynamic. I am in a position of power when they're coming to me as a patient. But what can I do to reaffirm that patients are parents are doing a great job by bringing their child to their appointment and recognizing all the positive things, whether they're just reading to their child as they're waiting to see me, as they're just hugging their child, right? And minimizing, giving them that compassion that they may need that no one else may have given to them in that situation. So we fortunately have the benefit that the U.S. Preventive Services Task Force is actually recommending that we as physicians actually ask these questions, which is great, and hopefully eventually get paid for, so that more and more clinicians will come on board and ask these questions, because that is one of the biggest barriers, is time and not getting paid for time. And that there are screening tools that exist out there. The one that I use is the Prepare tool, because this is what we have in our electronic medical records. And the reason that we're asking this, again, and hopefully it gets more and more standardized to ask these questions, but it really gets us to that root cause of what is going on in the community, and helps us understand our patients and the circumstances that that might be contributing. So earlier on, I talked about why a patient's not taking their Flovent medication is, when we look at that root cause analysis, right? Looking at what's going on outside of that health center, and that maybe it's just because they needed access to transportation. And then how such a simple thing as giving them the number to the Medicaid taxi can give them access to that transportation, or help create improved interventions. So when we talked about, Robin talked about making use of Lyft and Uber, and then how that's going to empower patients because now they have that tool. And in the end, this is lower costs, right? When we try to talk to people who are actually those legislators who are making these decisions, we have that power to make a change and have lower costs, improve actual outcomes, and then have that return on investment. And that's how we can talk to policymakers and hospital administrators and save money in the long run. So it's important that we think about this from a trauma-informed care approach, and that being having a systems-wide approach, right? So when we talk about making sure that we treat people as a person, not as a number, we are doing this in a sensitive way, and that when we see that person come in that might be labeled as that problem person, that difficult patient, that we see them more than just a number or that label. And then we look at them and ask, instead of what's wrong with you, you ask, what happened to you? And you engaging in them in that collaborative way. So I just want to put this framework that when we look at that person that may be, again, having these struggles and coming to us, and whether it's your client from the nurse family partnership, or someone who keeps missing appointments or just seems difficult, let's think about and give them context, right? Again, not what's wrong with you, but what happened to you. And then ask, right? Everyone's been affected by COVID in very, very different ways. And it's important that we remember that we've all been affected in different manners. Some people might see it as a way that, I wasn't able to go to school on a regular basis. I lost my job. I missed out on my prom. I missed out on celebrating my 50th birthday party, which is what I wanted to do. For some people, it might see something small, but for something that might have been a big deal because that's when they were going to see their family members. Some people may have lost family members. So recognizing that everyone has different ways that COVID has affected them and how they've coped with it. So ask and don't assume. And then recognizing that we have resources in the community, CJFHC being one of them, but also the importance of reaching out to them, and the importance of bringing routine into this in terms of coping with trauma, and then educating, because as we think about COVID as being an ACE, it's important that we talk about how COVID has been a traumatic exposure. It's been a traumatic stress, and it has caused trauma to our health. And how do we react to this? And then most importantly, self-care. As people who are working in this space in Central Jersey Family Health Consortium, it is important. So, talking about that oxygen mask that, when that's going down in a plane, that we have to put that mask on ourselves before we put it on our child. And working in this space, especially at Central Jersey Family Health Consortium, where you are working with individuals who have experienced trauma themselves, It's important that we take care of ourselves and recognize that we experience trauma in our own ways and stress in our own lives, and we can't take care of anyone else unless we take care of ourselves first. So what are the counter ACEs? So this is the good stuff. We can actually fight a lot of these adverse childhood experiences, adverse community experiences, especially as we talk about racism, COVID, and social determinants of health. So we need to talk about it in terms of nutrition, not just for ourselves, but for the people that we work with, exercise, sleep. For me, the stressors that I experienced during COVID as an ACE is that I found I started running more frequently and exercising more frequently. It was a way for me to get outside, which was very important. I think that was something that I found really helpful for me, just to go outside, be in a pause. And then I wasn't sleeping enough. So I made sure that exercise helped me with that. But kind of finding that moment for yourselves. What do you do as a counter ACE during COVID? But helping the people that you work with, your clients, find that counter ACE as well. And then most importantly, I think it's important to recognize that we, meaning me as a pediatrician in our primary medical home, we need to work well with others. We need to partner well with others. None of us can do this by ourselves. We need to partner with the great work that you all are doing, whether it's in the field of chronic care, acute care, preventive care, developmental services. I see so many familiar names on this webinar, and I'm so fortunate to be able to partner with so many of you. You have taught, I just want to thank, I need to give a shout out to a lot of you. I see Karen, I see Laura, I see, I feel like I'm in Romper Room. I don't know if any of you remember Romper Room, but, or was it the Magic Garden? One of them, I forget. But I see so many people that I've been partnering with to teach our medical students and our pediatric residents about the power of partnership. And you have taught our future pediatricians, our future physicians about the importance of the services that you provide and how we can work together to really work with our communities to better the health outcomes for our communities as we fight health inequity and health disparities. That said, I want to end with this slide, which is there's a lot of great work going out there, and there's some reminders that what we can all do, that we address social determinants of health as part of our healthcare delivery. We recognize cultural humility. I don't like cultural competency because I think that's the assumption that if you're competent, you're done, you're competent. Whereas humility is that we're constantly learning about other cultures. It's one of my favorite parts of my job. I work as a pediatrician, I work with people who are coming from Albania, Guatemala, India, China, West Africa, and hearing about their experiences, hearing about positive experiences and then the wealth of experiences that they bring in raising their children. And then using that trauma-informed care lens. For those of you who haven't taken that implicit bias test, I encourage you to take a look at it. Working with interpreters, working with who are we working with, who are the people that are delivering care, making sure it's diverse. And then looking at like the healthcare systems and how we deliver care and making sure that people are getting paid for the work that we're doing, the important work that everyone is doing, and then raise awareness through advocacy and working with community partners. So with that, I just want to thank you all for your time and thank you all for the work amazing work that you are all doing. I'm going to stop sharing and just see if anyone has any questions.
Well, there were no questions in the chat or the Q&A, but the feedback is remarkable. And I am just overwhelmed by this presentation and can't wait to re-listen to it when it's on the website, because I'm afraid I missed something. Thank you very, it was very, very informative, very well received by our audience as the comments keep coming in. So thank you very much, Shilpa. That was wonderful. And that will bring our presentations to an end. So thank you to both of our presenters as well as to the commissioner for her words. Again, on behalf of the board, I want to thank our presenters. I want to thank Robin and her staff for all their hard work, but all of our members for all the work you do out there in the community to help solve many of the problems that Shilpa has brought up. And with that, I'll turn it back over to Robin.
Thank you, Wayne. Thank you both Dr. Pai and Dr. Fisher for incredible presentations. Hopefully you have a minute to scroll through the chat. You can see the comments and frankly the accolades. And really, I think what is most striking, and there were a number of folks that said the same thing, is that the information you gave was very usable, very understandable, and something that we can take with us to use as we help assist, care our families to a better, a healthy environment. A huge thank you to all of you for joining us today. Until next time, I hope that you can stay safe, stay well. We hope to see you in May of 2022 at our usual time when we schedule our annual meeting. Hopefully it will be in person and not a virtual event, but we'll see how things unfold. The date is May 13th, again, 2022, which is hard to believe, at the Somerset Palace. So thank you for joining us, and best wishes to you all.